My name is Dr. Fernando J. Bianco. I work in urology specialist in Miami, Florida. I'm a clinical professor of urology for Nova University. I am the investigator in chief of the Urological Research Network. So this phase 1 clinical trial really focused on 20 patients and measure safety and efficacy and also reproducibility of this procedure in the office setting. That means in the urologist offices. What we did was that we used the transperineal technique under local anesthesia, and using fusion, we perform transperineal laser ablation on 20 patients. What we have found over the course of the initial 3 months, and it's been now sustained for 6 and 12 months, that there was a improvement in the International Prostate Symptom Score, or the AUA symptom score as well, of 10 points. We also saw an improvement objective in the maximum average, in the maximum flow rates of 10 cc's per second, and in average flow rates of 5 cc's per second. In addition to that, the post-void residuals were cut by an average of 60% on this study of 20 patients. In terms of the procedure itself, all patients completed the procedure. There was no significant adverse event. The fundamental side effect was hematospermia, which was seen uniformly among the patients, meaning that they had a brownish semen for a period of about 3 weeks. And all the patients preserved their erection during the started period. So their shim scores were unchanged. And again, they all preserved the ejaculation, with some referring that it has slight decrease in the amount of volume. Now, the fundamental premises of this technique is that patients can benefit by having improvement in the urinary outcomes measured by IPSS and objectively by flow rates, without a hazard in their sexual function rates. Furthermore, they preserve ejaculation, so it's a technique that spares the bladder neck, and because of this, these patients can indeed have ejaculation. Right, so the technical setting for a transperineal fusion ablation of the BPH tissue, it requires a ultrasound with a transrectal duplex probe. Okay, we in addition we use a digital stepper in order to understand exactly where our position on the prostate, and this goes into a fusion platform. The study was used the Focalix fusion platform that also was linked into in this case, the laser system that was used for the study was the Elesta Echo Laser 4, and this uses a guide that we can overimpose in our fusion platform called the ELS. It's just a director. And then what we do is that we do the fusion between the prostate gland, okay, and the plan of the BPH treatment to be executed. Then the laser fiber goes precisely into the spots presented on the plan, and then the ablation takes place. Usually we do 2 ablation areas. Depending on the prostate gland size, you may have to go and do 2 more applications. Each application requires anywhere between 3 and 4 minutes, depending on the wattage that you employ on the laser. The entire procedure during the study of the initial 20 patients, they had the application of the laser for less than 8 minutes total. And the room in and room out time was about 20 minutes. So the question is about the learning curve, right? And I think this procedure really follows, if it's done under the circumstances that we discussed, the premise of the old premise that we learned when we were residents. You see one, you do one, and you teach one. It's extremely easy to implement and execute. Just got to have a little bit of attention into the details that are involved. But once you've done one, once you see one and you have done one, you are ready to teach one. The control is really based on the fusion, on how you can have exact demarcations of the area that you want to treat, and then you see the energy delivering its purpose into that specific area. The way I put it many times for folks who come to the clinic and see this in real time is it's like playing a video game, right? You have your setup, and now you basically hit the objective that you want, like you would in a video game, and then you administer the energy. You use a pedal for that for safety reasons, so you can interrupt it or not if it's required. But with the block that we have developed and instructed to many folks, we are very confident that this procedure can be easily adopted in a massive way. Furthermore, since we did the clinical trial, we currently have now 3 separate sites that are doing this procedure, which has been performed over 150 patients in under 12 months of time. And I think it will be unfair, and it's not really to compare procedures like this one, or compare something like Resume to CHIRP, because the results are not the same. We're comparing this to novel techniques such as aquablation, right? They have a definitive role for patients who have a tremendous symptoms that require a procedure that essentially will change their lifestyle to some extent. When we think about transperineal fusion ablation, I would like to place it into more where a patient has an alternative of taking medication, they have to take every pill every day, and essentially have some adverse event from that medication, versus having a procedure, remedying the problem, and then basically going with the flow of this. For how long? Well, the data suggests with transperineal laser ablation that by a year the results are sustained. We'll see how they do over time. If we take the Resume model, we know that at least will last an 80% of them by a good course of 4 years. So the point is that these are procedures that have to be seen within the scope of the quality of life of the patient. There is no risk of erectile dysfunction, and there's really no risk of losing ejaculation. Once you go to a TURP or you go to aquablation, for example, you know that the bladder neck is essentially being demolished. And by doing so, those patients will not have antegrade ejaculation again. With this type of procedure, the paradigm is completely different. Okay, it's being done in the office, so you don't need hospitals, you don't need anesthesia. It's like a visit to a dentist where you just have your cavity fixed and you move on. It has a minimal impact in your daily activities, has a minimal impact in terms of your quality of life. If anything, will improve your urinary quality of life without that collateral damage. So I believe it has a role. It has a major role, I think, in young contemporary male who's starting to initiate this symptoms and who don't want to be exposed to 10 or 15 years of medication. So what was the adverse event profile of the trial? Because the trial proved quickly that within 3 months, that was the accrual period, we were able to prove that A, the procedure is tolerated well by patients in the office setting under local anesthesia. B, okay, that within the first month, the only or main adverse event was retrograde ejaculation. One of the things the trial did show is that only 60% of them were able to leave the office without a Foley, right? That 8 out of the 12 patients require catheterization because of elevated residuals immediately after the procedure. So that tilted us to a change in practice, in which when we do lasers, we keep the Foley for a couple of days and then we remove it, and therefore the urinary retention or elevated residual risk comes substantially down. So, and those were basically the major adverse events. We did not have patients experience infections. We did not have patients experience prostatitis, and in the trial, it was well tolerated. So from a safety perspective, the procedure When done under the technique that we show, using fusion as a big brother that's there helping us keep this safety standard, we can know exactly what is the area that we want to treat. We have a good perspective of where the urethra is, because the premise of this procedure is that it's not violating the urethra. And by not violating the urethra, we avoid, patients avoid, sorry, the urgency and the dysuria and all those irritative symptoms that occur once the urethra is stabbed or instrumented. So that's essentially the bottom line here, is that by going through the transperineal, we are essentially accessing, it's a percutaneous procedure. And, we give patients antibiotics just because of the Foley mobilization, not really because of the procedure itself. So the adverse event profile was one of minimal harm, really. And because of that, we see such potential in their clinical application.